A 64-year-old man with known ischemic cardiomyopathy, left ventricular EF 25%, collapses in the intensive care unit while being prepared for coronary angiography after a non-ST elevation myocardial infarction. He is found pulseless with ventricular fibrillation on the monitor. Advanced cardiac life support is initiated immediately. After 2 cycles of CPR with early defibrillation attempts and intravenous epinephrine, the patient remains in VF. The team administers 300 mg intravenous amiodarone, and high-quality chest compressions continue. Which of the following next steps is most appropriate according to current resuscitation guidelines? Immediate administration of 1 gram intravenous magnesium sulfate, regardless of electrolyte levels. B. Continue CPR for 2 minutes before the next shock attempt. C. Switch to asynchronous cardioversion at 200 joule biphasic. Administer sodium bicarbonate to counter metabolic acidosis. Perform double sequential defibrillation immediately. Correct answer, B. Continue CPR for 2 minutes before the next shock attempt. Explanation. In refractory VF, current European Resuscitation Council and American Heart Association guidelines recommend alternating 2 minutes of high-quality CPR with defibrillation attempts, minimizing interruptions. After initial shocks and drug administration, the priority remains maintaining perfusion with uninterrupted compressions before the next rhythm check. Magnesium sulfate is indicated primarily for torsades de pointes or documented hypomagnesemia, not for VF without these findings. Sodium bicarbonate is not routinely indicated in cardiac arrest except for specific causes such as hyperkalemia or tricyclic antidepressant toxicity. Double sequential defibrillation is not a standard first-line approach and lacks strong evidence. It is a possible rescue option only after multiple failed standard shocks in certain protocols. Key message: in refractory VF, maintain the CPR cycle, minimize interruptions, and only give targeted drugs and adjuncts when indicated by specific reversible causes. Question 2. A 58-year-old woman with septic shock secondary to pneumonia is mechanically ventilated and receiving norepinephrine. She has a history of hypertension and mild chronic kidney disease. After initial fluid resuscitation, 30 milliliters per kilogram, her mean arterial pressure is maintained at 65 millimeters of mercury with norepinephrine 0.2 microgram per kilogram per min, but urine output remains low, 0.3 milliliters per kilogram per hour. The intensivist considers further fluid administration but is concerned about the risk of pulmonary edema. Which of the following monitoring approaches is most appropriate to guide the decision for further fluid resuscitation in this patient? A. Rely on central venous pressure to assess preload responsiveness. B. Use passive leg raising with real-time cardiac output measurement. C. Perform a single measurement of mixed venous oxygen saturation via pulmonary artery catheter. D. Increase norepinephrine dose and recheck urine output in 1 hour. Calculate fluid balance over the past 24 hours and decide accordingly. Correct answer, B. Use passive leg raising (PR) with real-time cardiac output measurement. Explanation. In ICU patients with shock, the key question before giving more fluids is whether the patient is fluid responsive. It means whether cardiac output will increase meaningfully with increased preload. Static preload measures such as CVP are poor predictors of fluid responsiveness because they do not account for ventricular compliance or the shape of the Frank-Starling curve. Passive leg raising is a reversible, preload increasing maneuver that transiently mimics a 300 milliliters fluid bolus without actually giving fluids. When combined with continuous cardiac output monitoring via pulse contour analysis, echocardiography, or other devices, it is one of the most reliable bedside tests for fluid responsiveness in both mechanically ventilated and spontaneously breathing patients. While low mixed venous oxygen saturation may suggest inadequate oxygen delivery, it does not directly determine fluid responsiveness. Other factors like anemia, low cardiac output, increased oxygen extraction can influence it. Increasing norepinephrine without addressing potential hypovolemia risks excessive vasoconstriction and worsening tissue perfusion. Fluid balance calculation is helpful for global fluid management but does not predict whether additional fluids will improve hemodynamics. Key message: dynamic assessment tools like PLR, stroke volume variation, echocardiographic stroke volume change are far superior to static variables for guiding fluid therapy in critically ill patients. Question 3. A 56-year-old man is recovering from septic shock and is now lightly sedated on pressure support ventilation. Ventilator settings are: pressure support, 12 cm of water. PEEP, 8 cm of water. Fractional oxygen concentration, 0.4. Trigger sensitivity, flow trigger 2 liter per min. You notice on the ventilator flow, time and pressure, time curves, multiple small, rapid negative deflections in the pressure curve between assisted breaths. No corresponding tidal volume generation during these events. Flow curve remains at baseline during these deflections. The patient appears restless, with increased accessory muscle activity. Which of the following is the most likely cause of this waveform pattern? Autopeep causing ineffective triggering. B. Flow starvation due to low pressure support. C. Double triggering from high inspiratory demand. D. Reverse triggering from ventilator-initiated breaths. E. Expiratory valve malfunction. Correct answer: autopeep causing ineffective triggering. Explanation: the scenario describes ineffective inspiratory efforts. Patient tries to trigger the ventilator, but no breath is delivered. Key waveform clues: small negative deflections in the pressure curve without a delivered breath. Flow curve stays flat, no inspiratory flow generated. Seen in PSV, more common when intrinsic PEEP, autopeep, is present, making it harder for the patient's inspiratory effort to drop airway pressure below the trigger threshold. The patient must overcome intrinsic PEEP plus the trigger sensitivity to initiate a breath. This often occurs in COPD or with high respiratory rates and/or short expiratory times. Management includes reducing respiratory rate, lowering tidal volume, and/or increasing expiratory time. Flow starvation would cause a scooped inspiratory pressure waveform during assisted breaths, not ineffective triggers. Double triggering is characterized by 2 consecutive ventilator breaths separated by a short expiratory phase, usually when inspiratory time is too short relative to the patient's demand. Reverse triggering is seen in deeply sedated patients on controlled modes, not in spontaneously breathing patient on pressure support. Patient effort follows ventilator breath. Key message: in pressure support ventilation, missed triggers with flat flow curves often mean autopeep is present. Recognize and fix it to reduce patient effort and work of breathing. Question 4. A 68-year-old man with septic shock from abdominal sepsis is on norepinephrine and mechanical ventilation. He develops oliguric acute kidney injury with severe metabolic acidosis, pH 7.16, bicarbonate 14 millimoles per liter, lactate 5.2 millimoles per liter, and hyperkalemia, potassium 6.5 millimoles per liter. You decide to initiate CRRT, continuous venovenous hemodiafiltration. He weighs 80 kilograms, actual body weight, similar to predicted body weight. The ICU uses pre- and post-dilution replacement fluid plus dialysate. According to current KDIGO guidelines, which of the following is the most appropriate initial CRT prescription for effluent flow rate to achieve adequate solute clearance? Effluent flow rate of 15 milliliters per kilogram per hour. B. Effluent flow rate of 25 milliliters per kilogram per hour. C. Effluent flow rate of 35 milliliters per kilogram per hour. D. Effluent flow rate of 50 milliliters per kilogram per hour. Effluent flow rate adjusted only according to urea levels after 24-hour. Correct answer: B. Effluent flow rate of 25 milliliters per kilogram per hour, total. Explanation: effluent flow rate, the sum of dialysate plus replacement fluids plus net ultrafiltration, is the key determinant of small solute clearance in CRRT. KDIGO recommends prescribing an effluent rate of 20 to 25 milliliters per kg per hour to achieve a delivered dose of 20 ml per kg per hour, accounting for interruptions like clotting, procedures, or filter changes. Higher doses more than 25 to 30 milliliters per kg per hour do not improve survival in most critically ill patients but may be transiently used for severe metabolic derangements. Very low doses, less than 20 milliliters per kilogram per hour, risk inadequate clearance. The dose of 35 milliliters per kilogram per hour sometimes used for specific toxin removal or extreme metabolic derangements, but not as a routine starting dose. There are increases filter clotting risk and cost. Key message: for most critically ill patients with AKI on CRRT, prescribe 20 to 25 milliliters per kg per hour total effluent flow to ensure adequate delivered dose while minimizing unnecessary cost and circuit burden. Question 5. A 54-year-old man is in the ICU after a massive pulmonary embolism, treated with thrombolysis. He is mechanically ventilated and sedated. His ventilator displays end-tidal CO2, 22 millimeters of mercury, previously 34 millimeters of mercury. SpO2, 94% on oxygen 50%. Arterial blood gas, pH 7.41, partial pressure of arterial CO2 38 millimeters of mercury and partial pressure of O2 80 millimeters of mercury. Hemodynamics, heart rate 110 beats per minute, mean arterial pressure 68 millimeters of mercury, norepinephrine 0.08 microgram per kg per min. Which of the following best explains the current low end-tidal CO2 reading despite normal partial pressure of CO2? Increased CO2 production due to hypermetabolic state. B. Massive alveolar dead space from persistent pulmonary vascular obstruction. C. Hypoventilation due to pleural pain. D. Inaccuracy of mainstream capnography in high FiO2 settings. Air leak in the endotracheal tube cuff. Correct answer: 3. Massive alveolar dead space from persistent pulmonary vascular obstruction. Explanation: end-tidal CO2 reflects the partial pressure of CO2 in expired gas at the end of expiration and is normally slightly lower than partial pressure of arterial CO2, by 2 to 5 millimeters of mercury, due to physiological dead space. In this patient, end-tidal CO2 is markedly lower, 22 millimeters of mercury, than partial pressure of arterial CO2, 38 millimeters of mercury, causing widened partial pressure of arterial CO2 and end-tidal CO2 gradient. This suggests increased dead space ventilation. Alveoli are ventilated but not perfused, so exhaled gas contains less CO2. In massive PE, persistent obstruction causes large areas of alveolar dead space even after partial reperfusion. Increased CO2 production would raise both partial pressure of arterial CO2 and EtCO2 if ventilation is constant. Hypoventilation would raise both partial pressure of arterial CO2 and EtCO2, not cause a large gradient. Mainstream capnography is not significantly affected by FiO2 levels. Air leak in the ETT cuff can cause waveform distortion but typically leads to erratic readings, not a consistent large gradient with normal partial pressure of arterial CO2. Key message: a low EtCO2 with normal or high partial pressure of arterial CO2 in a ventilated ICU patient is a red flag for increased dead space ventilation, common in PE, severe hypotension, or right heart failure, and should prompt investigation into pulmonary perfusion.